how well you know Bob, but he's like a prince of a guy. He's a wonderful guy. So I'm delighted to be here. We've been working on making this happen for quite a bit of time, so I'm really happy to be here and talk to you folks. Can you all hear me in the back? Naomi, can you hear me? Can you hear me? Or should I do this? Oh, there you are. Is this good? You can hear me? Better? Excellent. Okay, good. And you can see? Good. So, as you heard, I'm Ed Weisbart. I'm a family physician. I practiced 20 years in Chicago, delivering babies and all that stuff. And I moved here in 2003, where I became the Chief Medical Officer of Express Scripts, which you may have heard of. And then I retired from that 3 years ago, and now I just volunteer at safety net clinics at Washington University and at a variety of places around the country, actually. So that's what I do. And then about a year and a half, 2 years ago or so, or as you heard from Bob, we began talking about this issue, about what real health care reform would look like, how we could provide health care to every American and actually save money doing that, because I am a fiscal conservative. So we began talking about that and organizing. We started with 100 people in St. Louis that we inherited. We now have over nearly 800 people. Actually, no, we crossed 800 last night. People in the St. Louis area that are interested in this topic and supporting us. So anyway, that's me. That's the background. I wanted to, what we're going to talk about is I'm going to give you an overview of how the United States healthcare system performs as compared to the rest of the world, because first we should talk about how we're doing. So we'll start with that, and then we'll talk a bit about why it's like that, and then we'll talk about some of the good and bad about the Affordable Care Act. And to just level set and make this be fully disclosing and honest, as Bob said, I personally support the Affordable Care Act. I think there's a lot of good things in it. So just to get that on the table, I think this is a step forward. But as you're clearly going to conclude from my comments, I don't think it goes anywhere near far enough towards really addressing the crises that our country and so many of our friends and neighbors are struggling with. So you'll hear about that and how I think we could do much, much better. So that's sort of the run of show, and then we'll take it from there. So is that what you were expecting for this hour or so? That's why you came into the room on this? Well, it's a dreary day. Where else could you go? Yeah, okay. So to start, let me show you a bit about how I got engaged in this topic, really. And this is from, I volunteer, as I mentioned, in free clinics around the country, actually. And this is one of them. This one was in Houston. And it's part of a series of free clinics that the National Association of Free Clinics hosts. And I help them recruit physician volunteers. So it's a one-day event. We've had 13 of these now. They're one-day events. We rent out... Oh, can you see now? Thank you. I might have done that the entire hour. So, thank you. It's a one-day event, and we rent out the biggest convention center in town. So we've done this in Washington, D.C., in New Orleans, in Kansas City, and in other cities around the country. And we bring in volunteers from around the country, actually, to take care of people without insurance for one day. So they get primary care, they get testing, they get prescription drugs actually for free, and we arrange follow-up care in the community for them. So it's one day. We usually don't go back to that city because there's need everywhere and it's expensive, and we do one day of it. This is, that's what 1,000 people in line. It's one thing to know that there's 50 million uninsured today. It's another thing to see 1,000 of them in line. And this is actually only one of 3 slides. There's another slide that turns the corner and has as many people. And then there's a third line that turns the corner again. So it's astonishing, really, to see 1,000 of them in line waiting for care. A couple things to notice about this line. First of all, they're well-groomed people. They're normal people. They look like you and me. They're dressed, you know, they're normal folks. And indeed, 83% of them come from a household where somebody works full-time. One of the patients that I saw at one of these clinics works full-time for the FDA, but doesn't have health care because her 5 teammates really work for the FDA, and her job was outsourced. So she doesn't really work for the government, but she works for the government, and she doesn't have health care. That's one thing to notice. They're normal-looking folks, like you and me, or your kids, or your grandkids, or whomever. The second thing to notice is that there's no real children there. We don't wind up attracting kids under age 18. Some, you know, we see maybe 1,200 uninsured people in the one day, and maybe 6 kids, maybe 4 kids. Because we have something of a solution in most parts of the country for children. Most parts of the country, there's a program called S-CHIP. There's a type of Medicaid for children in most parts of the country. We also don't typically see people over age 65 at these. I think in all of the events that I've been to for them, and I've been to 8, I think it is, we've had I've seen one person over age 65. Because again, most people over age 65 actually have some form of insurance. They have Medicare typically. So that's what the crowd looks like. This is what volunteers look like. And I'm here to tell you, volunteerism is a part of who Americans are. We volunteer. We work in food banks. We do stuff. We help people. If we see somebody hurting, we do what we can to help them. That's part of who we are. That's probably part of who humanity is, our species. But certainly in America, we tend to volunteer. We tend to like to volunteer. This is Dr. Bobby Kapoor. He's the medical director for this particular event. He's a really wonderful guy. This is what a room, that's about 2/3 of the room of volunteers. We get often 1,000 volunteers. I told you we see 1,000, maybe 1,500 patients. We put out the call for volunteers, and literally 1,000 people show up saying, I want to help. I don't like the problem, and I want to help. And what's really interesting, I think the way that this was set up is that this is this is not a partisan discussion. This is not a partisan discussion. And at these events, these are aggressively not partisan events. You talk to folks who are volunteering, and they come from every political spectrum, every religious spectrum you can think of, but we all meet at this common point of, hey, there's people hurting and I want to help them. So I think that's really astonishing and very inspiring about who we are as a nation. We help each other. But we could do 1 million of these events, and it wouldn't solve the problem. It's unbelievable how many more of these we need to do. So volunteerism is terrific. It's a huge part of my life these days, but it's not ever going to be big enough to solve really the problem. So I know some of you are probably thinking, well, you know, I've got insurance. I mean, is this really an issue that I should pay attention to? And I'm here to tell you the answer to that is yes. If it's not about you, then it's about your children or your grandchildren and the future. And it's about America's ability to compete globally with the rest of the world. It's about a lot of things that do directly impact each and every one of us, whether we have or don't have insurance. So I'm going to show you a few of these charts. They're not really very easily read. That line on the bottom, that's a bunch of countries. Don't worry about trying to read that. That's not the point. But you'll always see the blue bar. Can you see the blue bar in there? That blue bar is the United States. That blue bar is the United States. So you'll see that and judge where we are. So if you're thinking about a healthcare system in a country and there were one number to look at, that number probably is life expectancy. Because life expectancy is why we have healthcare. So life expectancy. And until I started having these discussions, I assumed that we, like in everything else, that, as I assumed, we're number one. Well, in life expectancy, we're not. In life expectancy, we're not. We're actually down there on the list. And a lot of things impact life expectancy. So, you know, it's a complicated issue. But in life expectancy, we're not. So, but there's something really, you probably saw that chart before. You probably haven't seen this chart, and it's a little more complicated, and I'm sorry. But I told you that we rank 37 in the world, of countries in the world, in terms of life expectancy. That ranking 37 depends on how old you are. It depends on how old you are. So 37 is for all of us. But if you look at this, and this is from a little different source, so it's a little different numbers, but if you look at this, our ranking all the way to the left is in the 30s, right? So kids, people at age 20, 30, 40, 50, 60, again, for all of people that age group, our ranking is in the mid-30s. And then something amazing happens when you turn 65. Look at that. When we turn 65 and we get access to Medicare, our life expectancy rankings in the world recover. And we start to once again become the American nation that I was brought up to believe in. If you get Medicare, if you give everybody health care in the country over age 65, all of a sudden, our life expectancy ranking in the world starts to recover the place that American things should be at. Now, we've got 65 years of neglect before age 65 as a population, so you can't get back all the way up to where we belong. But did you know this? I didn't know this a year ago. Did you know this? It's amazing that, and this is part of what, I mean, so Medicare is far from perfect, and we're going to point out some flaws, but oh my gosh, it has an amazing impact on our lives. So, this is a wonderful quote. Every system is perfectly designed to get the results it gets. Every system is perfectly designed to get the results it gets. This is important. It's not, the difference in our life expectancy is not because the genetics of Americans are different from the genetics of Italians, are different from the genetics of Croatians. It's not, it's got nothing to do with that. It's entirely, because we are all those people actually, it's entirely about our systems, which means how we perform in healthcare are decisions that we make. So we're going to talk about that. So just a little bit more. We have lots of technology, and I could have shown you 30 of these slides, but you know, this is just the number of MRI scanners per person in the population, and we lead the world at high technology. We have the most high technology. We lead the world at outcomes from diseases that require high technology. Cancer is a great example. Any kind of cancer except for two, and I forget which two they are, I'm sorry, I need to look that up, except for two, and those two were number 2 in the world. For all of the others, we are number 1 in the world for 5-year outcomes for any kind of cancer. Any kind of cancer, except for 2, where we're number 2. So that's why you see people from other countries who have the means and live in a country that doesn't provide the same kind of care, you see them coming here, because for high-tech problems, we're great. We actually lead the world. And if you think about that, that's the decision of our business model, right? If I'm, oh, can you dim the lights? That would be great. Oh, great, that's better. So we have a business model for high-tech things. If I'm a gastroenterologist, I can get at least $1,000 oftentimes for doing a colonoscopy. If I'm a radiologist, I want to open up another PET scanner, because there's a business model for these high-tech things. And that's part of why we have such spectacular outcomes in high-tech problems. On low-tech problems, this one's infant mortality, we are the opposite extreme. This is kids who die within the first 30 days of life. We lead the world in those kinds of deaths. We lead the world in maternal mortality. Maternal mothers that die within 30 days of delivering, we are the worst of modern nations. So if you think about that, you're not going to solve infant and maternal mortality by opening up another ultrasound machine. That's not the problem. That's not the solution. Maternal mortality, infant mortality, and many other public health problems are low-tech kinds of problems. They're public health. They're smoking. They're early prenatal care. They're nutrition. They're exercise. They're lifestyle. And we don't really have a very strong business case in our current system for aggressive programs around that. So we lead the world in high-tech. We really don't do that at all on low-tech problems. And most public health, most life expectancy issues have more to do with that. We're great at getting in to see specialists. This is waiting time to see a specialist. And as you can see, we have some of the shortest waiting times to get in to see a specialist. And I'm pretty happy about that. We have among the shortest times for elective surgery. So I'm pointing this out because Canada, for example, is on the far right of this particular chart. And as you're going to be hearing, part of what I'm proposing is that we move more towards the Canadian model. But they don't do so well here. A couple things about that. So this is elective surgery, right? This isn't you break your hip. This isn't an emergency. For emergencies, you get in just like that. This is elective stuff. And the number, it's hard to read, but the top of that chart there, that's 25%. So 25% of Canadians in this survey waited at least 4 months for elective surgery. And I'm here to tell you, Canadians hate that. You do interviews on the street and ask Canadians, what do you think about waiting 4 months for, and they'll say, well, you know, I was working and the arthritis in my knee got worse and now I have trouble getting up the stairs at my office and it's a problem. I don't like that and I'm in pain. I'm not at all happy about waiting 5 months to get my knee replaced. And the doctor said I need that. I don't understand why I have to wait 5 months when the doctor thinks I need that. That's a problem with the Canadian system. Not for emergency, life-threatening problems, but for elective kinds of surgery. So Canadians will quickly say, I hate this about my system. But in the next breath, they will all also say, but if I get the cancer, I'm not going to go bankrupt. If I get cancer, they're going to see me immediately. They're not going to ask me how much money I make. They're not going to ask me for anything. They're going to get me in immediately, and I'm not going to have to go to the poorhouse, and I'm going to get everything I need. And so you know what? I'm actually okay with that trade-off. That's what Canadians say. That's what Canadians say. And it's a handful. It's double-digit numbers. It's under 100. It's a handful of Canadians who come to our country specifically to get some health care that they have difficulty getting in Canada. There are some, of course, but it's incredibly small numbers of people that do that. So the other thing to bear in mind, as I'm going to show you, is that they spend half of what we spend on health care. And nobody's talking about cutting our health care costs down 50%. That's not what we're talking about. So if we just keep spending at the rate, at the level that we're spending it, there's no reason we ever have to run into this Canadian problem. That's just not, that's so, but even if we did, like I said, they think that's way better than having the problems that we have that I'm starting to show you. So we don't go to the doctor very much. You can see the blue bar, we're near the left there. And when we show you the cost of what we spend again, it's pretty surprising that we don't actually get that many doctor visits per year. We don't even have that many doctors considering what we spend. There we are. So we spend an awful lot, double, and we don't even have that many doctors or go there very much. How can we spend double and not go to the doctor very much? What's going on? It's actually pretty easy arithmetic, but we'll make that more clear in a minute. So we lead the world at administrators now. This is where we're number one, so that's we should be proud, I guess. Our spending, I started to show you, our spending is double what the rest of the world spends, more than double for most countries. I'm sure you've seen this, I'm sure you've heard that number, but you may not have seen this, and this is very important. This shows you the blue bar is what we spend from taxes today. So our taxes today are more, what we spend in tax dollars on healthcare is more than any other country spends on healthcare in total. Our taxes today, we spend more in our taxes today than any other country spends in total. And our taxes, that blue bar, that only covers about 28% of us. And the green bars, the rest of the world, they cover everybody. So the reason I'm pointing this out to you is when you hear people say, well, sure, I like the way that they do stuff in Sweden, or pick a country, but do you have an idea what their taxes are like? We can't possibly have taxes like that. I can't possibly even imagine that. I'm here to tell you our taxes for health care are already worse than the taxes are for health care in any other country, and we don't get nearly what they get for this. So I'm a little, we're not getting the value. Let me make this a little more real. So why does it cost so much? People will say, well, it's because we smoke a lot. It's because of the baby boomers. It's because of all these other things. So we're actually not an old country. We're actually not an old country. The percentage of our population who's over age 64 is lower than in almost every other modern nation. So it's not because we're old, and as you know, older folks have more health concerns and spend more, because they should. That's not the reason that our costs are so high. We're not old. We're a young country. It's not because we smoke. We actually smoke less. I don't know if you can see that. It's a little blurry. I'm sorry. We smoke less than most other nations, 15%. 9 days ago, I came back from Barcelona. So here's where Missouri is, right? Spain is right to left to it. So in Missouri, we have like no cigarette taxes. We have really, really low cigarette taxes. So we smoke like Europeans do in this country. So I actually just got back from Europe, from Barcelona 9 days ago, and I saw some friends of mine from other countries, from other states in Barcelona, and they said, can you believe how much of these Spanish folks smoke? And I went, well, it looks like St. Louis to me. Looks like Missouri. I don't know. I don't see the difference. And they were like shocked. It looks normal. So anyway, we are obese. So we lead the world in this. I know you know this. This is not the driver of our costs today. So obesity, first you get obese, then you get hypertension, blood pressure, diabetes, and all that stuff. So we clearly have the obesity epidemic. We clearly have the onset of blood pressure and diabetes problems among the obese. Those things aren't really themselves that expensive. It's the third wave. There's obesity, there's blood pressure and diabetes. The third wave of heart attacks, strokes, and those things, kidney failure, that's where the expense will come. So if we don't, that's coming. We haven't really hit the financial implications of that yet. If we don't fix obesity, it's going to come it's going to really hit us hard. So we have to fix the economics, which is what we're talking about, the economics. So we waste a third of what we spend. 31% of what we spend, you go to see your doctor, and you see me, and then I've got my nurse, and I've got my receptionist, and that's just lovely. And then there's 4 people you don't see who are shuffling paper in the back. One of them might be up front helping you figure out where to go for your CAT scanner that's in network. And the other 3 are helping me submit my bills and claims and things. And hospitals have floors full of these paper shuffling folks. Literally 31% of what we spend on health care is the insurance model that we've chosen to elect. Canada, it's about 10%. Medicaid in Missouri, I happen to have served on the Missouri House Interim Task Force on Medicaid this past summer, so I saw their numbers. Medicaid in Missouri, overhead is 2%. 31, 2. Most European countries, it's in the 3 to 5% range. And Medicare is 2 to 5%, depending on who you read. So 31%. That's not helping any of us. So there's an opportunity here is the message. Let me give you one example. Anybody want to guess? It's hard to see, so maybe you can't. I won't have you guess. So this is a woman suffering from hot flashes from menopause. And you probably have heard of hot flashes in menopause. So what you may not have heard is that sometime this week or next week, I don't know when, but it's coming to the market, the first drug to get an FDA indication for treating hot flashes of menopause. Cool. I mean, I would actually pay probably about $1 million for that drug. But, this is the new drug coming to market to treat hot flashes. It's called Brisdell. Brisdell. Wonderful. Okay, so what is Brisdell, this new breakthrough in treatment? Brisdell, you probably can't read it in the fine print, is a drug called paroxetine. Brisdell is paroxetine. It's 7.5 milligrams. Okay, so what? Well, paroxetine is also Paxil, which you probably have heard of. Paxil, Zoloft, Prozac, it's an antidepressant. It's an older antidepressant. Its patent has expired. It's the same drug. It's the exact same chemical. Paxil, you usually dose 10 milligrams, 30, 40, something like that, 10 to 40 milligrams. I believe the lowest dose of Paxil that they make is 10 milligrams. Brisdell is 7.5 milligrams, so it's a slightly lower dose. It's really the exact same thing. I mean, there's no clinical difference between these 2 dosages. So Paxil or paroxetine, that's what this new drug is. So Paxil's patent is expired, and you can buy generic paroxetine almost anywhere. It's on all the $4 lists. So you can buy a bottle of 30 paroxetine, 10 milligrams, for $4 almost anywhere. Anybody want to guess what Brisdell is expected to be priced at? You guys are triangulating it. It's 135. 135. So they're anticipating that that's the price for the same drug. $10 or $4 for 10 milligrams, or $135 for a slightly lower dose. This is cray-cray, as the kids say. I think I disclosed to you that I spent 8 years as chief medical officer at Express Scripts. You probably have heard of Express Scripts. I still think, actually, it's a spectacular company that does some spectacularly good things. And one of their missions is to lower the cost of prescription drugs. That's still happening. This is still happening. The Veterans Administration actually has lower prices on most drugs than anybody else in the country does, because they have the power of the government. Medicare does not. Medicare does not have lower prices, because when they made Part D of Medicare, they brought in somebody from the pharmaceutical industry to help write part of the law, and they insisted that that law not permit the government to negotiate prices. So you've probably heard this. Part D, the government is precluded from negotiating for the prices of drugs and reimporting drugs and things. And then once they got Part D established, then this guy went back to the pharmaceutical industry, Billy Tausen. So this is still happening. So I mentioned to you, we don't go to the doctor very much, but yet we spend a lot of money. The issue, of course, is price. It's all about price. And if you haven't seen this article, Time Magazine, March 2013, you should try to get this. It's a pretty impressive article. And they go through how insane pricing is. But the problem is that there's nobody really in our country, despite how great I think companies like I just described are, there's really nobody who has the power and authority to negotiate as aggressively as they do in the rest of the world. And as a result, our costs are through the roof. It's one of the issues. So you all know that we have a problem with 50 million without insurance today. You may not know that we will have that we also have a problem with an even bigger number of people who have crummy insurance. They pay more than 10% of their income on insurance, on health care. More than 10%. That's called underinsurance. That's called crummy insurance. And we're actually kind of normalizing this. That's becoming the new norm. As we fix some of the uninsured, most of them are going to get underinsured. They're going to move from red to pink. And many of the people in the green are going to move into pink. So underinsurance is becoming the new norm in the United States. I consider that unacceptable. Why? Well, let me give you one example of what that means. It means that deductibles are skyrocketing. In 2006, 10% of workers had a copay or a deductible over $1,000. And in the last 7 years, that 10% has gone to 38%. So then 1 out of 3 workers in the United States of America has a deductible of over $1,000. That's new. That wasn't the case 10 years ago. So the costs are shifting to workers. It's part of if they pay the price, then they're going to understand it and they're going to help control the cost. That's the logic, right? The logic is if we have Americans pay more for their care, more of the care, then they will become smarter consumers, and that's a strategy to control costs. Sounds good. It works in automobiles. It works in wine. It works in lots of things. It doesn't work in healthcare. It doesn't work in healthcare because it's not really a market economy. Most of you just sort of go where your doctor tells you. You don't have, when you're sick and your doctor says go such and such a place, you're not going to, it doesn't really work in healthcare. And as a matter of fact, in the United States, we have more of that skin in the game, where we're responsible for it, than any other country, and yet our costs are double. So if that strategy were going to work, if this strategy were going to work, it would already have worked. So anyway, this drives bankruptcies. If you think about it, somebody is working, they feel fine, and then they get sick, and then they can't keep working, and then they lose their insurance. That's the most common pattern of bankruptcy in the United States. And as you can see, most of them did have insurance when they first got sick. So I'm going to skip through that. There's good things in the Affordable Care Act. We're going to get millions of more people with insurance. That's undoubtedly the case. And there's the Patient Bill of Rights that many of us in healthcare have been fighting for decades is actually it's embedded in the Affordable Care Act. So you've probably seen a lot of these things, and I'm not going to walk you through them. There's the marketplace, which if you have a TV in your house, you've heard about the marketplace. And I'm not going to belabor that, but that's a way for people to get access to health care. And then Medicare itself is actually stronger. The trust fund has been extended out longer than it usually is. It's actually, Medicare is more financially stable, not less. And then there's all the issues with Medicaid that are a little beyond the scope for today. So if you want to talk about Medicaid afterwards, I'd be glad to. So anyway, and there's a lot more. And so we're going to skip through this just for time. So there's problems with the Affordable Care Act, these problems, which we sort of hinted at already. But the biggest problem in my mind with the Affordable Care Act is this. It's that we took somebody from the insurance industry, Liz Fowler, who was an executive at WellPoint, and asked her to help us. She wrote a lot of the legislation that is the Affordable Care Act, and then I believe she's gone back to that industry. So the Affordable Care Act immortalizes the insurance industry rather than aligning health care with the public's needs. So it's completely different from what any other country does. And I believe that's a problem. I'll give you an example of why that's a problem. So a friend of mine was a medical director at a health plan in Chicago where they noticed that there were a lot of people with congestive heart failure. And if you're familiar with that disease, you know it's oftentimes sort of follows almost a relentless course, sometimes not, but it's often sort of relentlessly getting worse over time. And so he saw that a lot of the patients from their health plan were getting readmitted to the intensive care unit over and over again every few months. And so he put in a program, which at the time was cutting edge, and now it's sort of normal, where he gave people scales so they could weigh themselves and other educational stuff. And in 9 months, the number of people being readmitted for congestive heart failure fell by 50%. 50%. And then the hospital that owned the intensive care unit called the insurance company and said, hey, what's going on? We got this intensive care unit that's sitting empty. Where are all your patients? And they made them stop the program. So they stopped the program. That's what happens when you don't align economics with public health. That's what happens when you don't align, and that's what's different about us. That's where we fail. That's why we have all those MRI scanners, but yet we have infant mortality, and we don't have the life expectancy. So here's a little quiz. How many people are involved? I have 4 of these. How many people are involved in medical bankruptcies every year? How many people do you think in the United States are involved in a medical bankruptcy every year? Pick a number. How many?
About 30.
About 3?
No, it's
30? 30 people. Actually, it's more like 30%. Yeah, well, it's not that bad. It's actually about 2 million Americans are involved in bankruptcies that were driven by a medical cause every year. And it's probably worse than that. Maybe it's closer to your number. It's probably worse than that because if you're really poor, you don't even declare bankruptcy, of course. So anyway, that's the number. How many people in Canada declare bankruptcy for medical reasons? It's a smaller country than we are. So how many? 500,000. Any other numbers? Bankruptcy for medical reasons in Canada. Yeah, it's 0. This doesn't happen anywhere else in the world, in the modern world. 0. Nobody, no, it doesn't happen. Okay, question number 2. There's a pattern here, so pay attention. Question number 2. How many people in the United States don't have health insurance after the Affordable Care Act is fully implemented? How many people will be uninsured in the U.S. after the Affordable Care Act is really on board? I told you we have 50 million today. How many are we going to have after the ACA is fully on board? Yeah, 30 million. 30 million. How many people in Canada don't have health insurance? 0. Yeah, 0. 0. 0. That's an important number. It's a big number. It's a really little number. 0. Okay, number 3. How many people go without some medical care because of cost? You know, you see me and I tell you you need 10 physical therapy treatments, and so you only do 5 because you can't really afford the other 5. You see me and I prescribe insulin for you, and you start taking the insulin every other day because that's all you can afford. You see me and you've got a blockage in the artery in your neck, and you've had these mini strokes, and I'm telling you we need to go get a test on that and maybe surgery, and you're 64 years old and you don't have insurance, so you're thinking, I'm gonna hang on and pray until I'm 65, and then you may or may not make that. I've seen every one of those people. I didn't make that up. I've seen every one of those people. Okay, so how many people is that? How many people go without some medical care because of cost in the United States? A lot. Yeah, that's the right answer. 115 million. 115 million. That's morally repugnant to me. 115 million in the richest country in the world. And how many in Canada, class? 0. Very good. You're catching on. So you were doing better at this than the group of medical students I had this with. They didn't know. I think it's going to be 65. You know, it's very good. You got the pattern. Okay, last one of these. How many people die every year from not having insurance? So I'll tell you, I'll fully disclose, my nephew is one of these in the year 2006, I think it was. I'm not going to tell you that story unless you want to hear something really morbid later. But how many people die? And I'll give you a clue. This is an arithmetic quiz. The data comes from a year when there was 45 million without insurance, and they concluded, after they looked at it, that it was 1 out of 1,000 without insurance die every year. So 1 out of 1,000 without insurance die every year. There were 45 million, so I can hear the gears turning in your head, and you're right, it's 45,000. 45,000, probably now 50,000, die from not having insurance. And how does that work? You know, it's the things I told you. It's the person who gets some abdominal pain, you know, a little achiness in their stomach, and maybe some bleeding, and they think, oh, this is hemorrhoid. It's a hemorrhoid. I'm not going to go to the doctor. And they wait, you know, and it doesn't really get better, and they wait, and it doesn't really get better, and 6 months, a year go by, and they finally come in and pay out of pocket. They come in, and we see them, and we say, well, you know, you got blood on the stool, and you got abdominal pain. I'm a little worried about this. It's been going on for a year. You need a colonoscopy. And they go, well, that's like going to cost me about $3,000. And guess what? That's more than my rent. You know, do I sell my house? Or my apartment? Do I move out? Do I get evicted? I don't have $3,000. And then, of course, what happens if you ignore things like colon cancer? It's not happy. So that's what happens. This number is real. This really happens in our country. People die from this problem, and that's why we're talking about this. What's the number in Canada, class? 0. Yes, this doesn't happen. Doesn't happen. All right, enough of this. It's kind of morbid. So we're going to go into the solutions in just a moment. But before we do that, I'd like to ask Bob and Naomi, If you like this kind of discussion, if you're interested in this discussion, if you want to hear about new things as they come out, if you want to hear about new presentations that we're giving or speakers we're bringing in about these topics, Bob and Naomi are going to pass around our sign-up sheets and give us contact information. If we don't have your email, if you don't have email, don't fill it out. We're not going to call you. We're not going to send you mail. We don't have that kind of budget. We don't have a budget, so it's got to be email. I'm sorry. So fill it out. And please, 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 my wife is the one who transcribes this into our computer, and she gets really mad at me when she can't read things. So if Mama ain't happy, Papa ain't happy. So please, please, please write really, really, really clearly, please. So anyway, did I make that clear? Yes. She'll be happy if you do. Anyway. So if you want that, and go ahead. So we're going to get to that. We're going to. Let me make the last comment about this, about the sign-up sheet. There's a column there all the way to the right that asks you if you have an organization that you want one of us to speak at. There's a few of us, and we'd be glad to come out and speak. So if you do have somebody if you do have a church group or another club or some other organization, a partisan, labor, some group that you would like to have one of us come to speak to, please just check the box. And we've got a guy, Tommy Flanagan, who volunteers, who will reach out to you and work that out with you. The question you asked was would it pass even? Could we have gotten anything more than that? And we'll get to that. No, no, you guys aren't leaving for a while yet. No. We're about midpoint, 2/3 of the way, something like that. Anyway, so let's talk about health insurance around the world. This is the way it's structured in the United States. So it's structured with huge gaps, and you have to look at a directory to find your doctor, and the overhead is huge. That's called multi-payer. The rest of the world, the modern world, uses what's called a single-payer model. And there are many flavors of that, so every country is a little bit different. Let's talk about Canada's model for a moment, and then let's talk about England's model. Those are sort of the two extremes, perhaps. So Canada has what they call Medicare. Canada has what they call Medicare. And actually, Lyndon Johnson in 1965 took the word Medicare from Canada because he liked it. So Canada has Medicare. And that's just like our Medicare in many ways. You pay your taxes, and the government manages that, and then the government pays your doctor. And so there's no, the doctors are in private practice in Canada. The doctors work for themselves, for a group, for the hospital. They're not employed by the government. That would literally be socialized, and this is socialized payment, but that's what all insurance is. So that's private practice. That's called national health insurance. England does it differently. England does it more like the VA, where they actually employ the doctors and own the hospitals. That's a national health service. That's truly socialized medicine, and that is not anything that I think makes any sense in the United States, although some talk about that, but hardly anybody. So there's different flavors of this. But as I told you, their overhead is almost nothing compared to ours. So that's essentially the model. And that's what we're talking about. We're talking about taking Medicare. What's magic about turning 65? Take Medicare, fix the problems with Medicare, because we all know that there's problems with Medicare, and then give that to everybody. Give that to everybody. So we would fix the problems. As you know, there's huge gaps. Almost everybody on Medicare has a Medicare WRAP program. You wouldn't need the Medicare WRAP program if Medicare covered the things that you actually need. So fix the problems and preserve private delivery, and then give that to everybody. Roll up all the payment streams we have today. Roll up all the money that's already going in and have everybody in the same program. If everybody were in this program and nobody out of the program, then the program wouldn't be under attack and marginalized all the time, as Medicare is constantly under attack. I don't need to tell you that. Medicare is constantly under attack. Medicaid is incredibly marginalized. If everybody, and I mean everybody, Congress, President, senators, fire people, I mean everybody were in this same program, you would avoid that problem, so including Congress. And there's a bill that says this. It's the Improved and Expanded Medicare for All Act. It's H.R. 676. If there's one thing I want you to remember from this discussion, it's those 5 numbers and letters. H.R. 676. H.R. 676. It's the name of the bill. It's sponsored by John Conyers. Lacey Clay is one of the co-sponsors. There's 48 co-sponsors in the country. It is actually the most popular piece of health care legislation and the most advanced other than the Affordable Care Act. It's actually got legs. It's not going to be passed tomorrow, but that's the bill. I want you to go home and Google this and read it. It's about 30 pages, double-spaced, in plain English. Yes?
I know that Congress doesn't have the same insurance that they signed off on for Obamacare. I don't know exactly what kind they have, but I think it's more like a platinum or better.
So the congressional aides are now using, or will be now using, the exchange with so they'll be buying it from the same places that everybody in that community will be buying it from, with a subsidy because guess what? Every employer pays for health care benefits to a certain, or lots of employers, not every, and they were paying for their health care, so they're giving a subsidy. So I'm far from expert on that, but they're in this pool. Under this program, everybody would be in this pool. So I encourage you to read this. It'll take you an hour, maybe 2 hours. It's easy to find. Google HR 676, and then you'll know what we're talking about in more depth than we're going to be covering today. It covers, this is what's in the bill, it covers all the important stuff, and I'm not going to belabor that list with you. It's all the things that you would think. These are the gaps that you have today that we fill things for, so you all know that there's gaps, and I'm not going to beat that up on you. But one of the most important things, of course, is that the bill thinks about that there's hundreds of thousands, probably, I don't know the number, of people working in the insurance industry who would become displaced by what we're proposing, because there wouldn't be a need for insurance in the same way that we have it today. So there's a few things. There's a transition plan thought out for them that's funded. There's guaranteed salary for 2 years, no matter what happens to their company for the first 2 years after the bill were passed, up to $100,000, and then they could go to unemployment. So there's thought about that. There's priority for job training and such. And job training doesn't mean this. I don't know if you can see that. Hamburger University. I lived in Chicago. I had one of the 25 or so offices that I managed was in Oak Brook, Illinois, and Hamburger University from McDonald's was down the street and had wonderful convention center that we used every once in a while. With cute little the door handles had cute little pictures of the Golden Arches or something. It was really adorable. But anyway, that's not what they would be retrained for. If you think about it, one of the problems is, well, if we're going to cover all these people, who's going to take care of them? Who's going to do all the work? And I'm here to tell you there's an awful lot of highly skilled and smart, intelligent, clinically trained sometimes people who are interested in health care who will be out looking for work if we do this. So this program plans 2 years of helping them figure out the skills they need so that they can be contributing to health care rather than health care shuffling. So it's a pretty good thing, I think. Anyway, retraining them. And it would be based on the income tax model, progressive income tax, where the wealthier would pay more than the poor would pay. And at the end of the day, and you would get rid of premiums and copays and Medicare wrap premiums and all that. And at the end of the day, 95% of us would pay less, not more, on our health care. So that's a compelling argument. And let's go through this a little. Well, let's skip this. You can look at the analysis of it, but at the end of the day, we would save money and cover everybody. So I could go through the detail about that, but time's kind of escaping me. So let me, and the investment community is all about this. That's the Motley Fools. They're one of the leading investment advisors, and they agree that this bill would save a fortune. So Canada has figured this out, right? Here's the relentless curve of our healthcare expense as a percentage of GDP. You've seen this chart before. We're up to like 18%, I think, now. So it's a big part of our GDP, right? And it's been on this curve. Here's Canada's curve. You probably haven't seen this. And what I want to point out to you is that up until about 1970, Canada was on the exact same curve that we were on as a percentage of GDP. Interesting. And then something happened around 1970. What happened in 1970 in Canada? They fully implemented their national health program. And as a result of that, their costs are now half of ours. Well, I saw this, and my first worry was, well, okay, so they spend less. How good is the care up there? What's happening to their life expectancy? And so I pulled that data, and in 1975, the oldest year for which I have the data here, Canadians were living 1 year longer than Americans. In 1975, Canadians were living 1 year longer than Americans. I don't know why, but they're Canadians. I don't know why. So what happened after that? What happened to their life expectancy? Remember, their costs have gone down to half of ours. They were on the same curve. What happened to their life expectancy? As you can tell from the way I drew the curve, something. So over the intervening, 40 years, their life expectancy is now 2.5 to 3 years longer than ours. So when I was 29, if you told me that there's a way to make my life expectancy 1.5 years longer, I would say, yeah, right, so I'm going to be 82 instead of 80.5. I'll be, all these insulting things in my head about what that would mean. I don't really care about that part of my life. Why would I care? Well, I'm 59, I'm going to be 60 pretty soon, and that 1.5 years is important to me. I don't want somebody messing with it. That's an important 1.5 years, and it's not mine. The other thing to think about this is Canadians should be showing slideshows about the United States. Italy should be showing slideshows about the United States. It drives me crazy that I'm up here showing slideshows of how much better it is in other countries. That's not the United States that I believe in, and I'm going to come back to that point. So, anyway, Canadians don't come here. If you look at border states, only 900 of them come here every year, and most of them were coming here for travel-related reasons. They didn't come here on their own. Only about 150 actually come just to get health care. 150, that's not a lot of people when you think about it. Canadian physicians are staying in Canada. 20 years ago, they were coming here. The last 10 years or more, Canadian physicians on net leave or go into Canada rather than leave Canada. Canadian doctors, we all know doctors from Canada who moved here 15, 20 years ago and who are unhappy about the Canadian healthcare system. And I'm here to tell you they're real. I know some of them. They're very small numbers. Most physicians in Canada are very happy, and there's actually physicians moving into Canada, not out of Canada. So let's put that to bed. They did a survey asking folks around the country, are government programs like Medicare and Social Security worth the cost? So is Medicare worth the cost? And guess what? Most Americans say yes, Medicare is worth it. 3 out of 4, 76% of Americans say Medicare is worth what the government spends on it. 3 out of 4 Americans will say that. And then they asked the Tea Party, well, what do you folks think about this? And again, this is a completely nonpartisan presentation. This is not about either political party. It's not about the Tea Party. I'm bringing them up to you because I think they would agree, I think you all would agree, that this is a group of people for whom not wasting government money is really important. Do not squander a penny of these precious resources that you got from my taxes. That's really important to them. So just a reality check here. Raise your hand if you think wasting government money is a good idea. Not so much? No. I mean, we all agree with that. There's a lot of other things we could talk about the Tea Party all day, but I mean, they probably would, I don't know, I think they would agree that that's a really important deal to them. They're very fiscally prudent about government resources. So they asked the same question to the Tea Party. What do you think about this? 62% said actually Medicare, Social Security, that part's worth it. The reason I'm telling you this is if you watch TV, you get the sense that we are an incredibly polarized country, that we've all seen the moment on TV where somebody said, let him die. We've all seen this stuff. You would think we have red states, blue states, and nothing in between. And I'm here to tell you that Americans are a country of volunteers. We help each other. We nurture each other. We don't kick the ball down the street. If somebody is suffering, we help them. We do this kind of thing. We volunteer. We think programs that help those in need are good, generally. Not all of us, but the vast majority of Tea Party folks also think that Medicare is worth the expense that the government spends on it. I'm just making a point. It's very hopeful to me. We are a country that cares about these things and that cares about each other. We have different philosophies. We have different ideologies. We come to these points from different points of view, but at the end of the day, we believe in what the good Reverend just told us almost an hour ago. We believe that. We all believe that, no matter what our philosophy and religion may be. We care about each other. That's who we are. So physicians believe this. 59% of physicians support National Health Program, more in primary care specialties, less in some of the subspecialties. I'm showing you this because, let me just tell you, I've been a fan of this strategy for decades. I didn't start speaking to anyone about this until about 3 years ago or so. Because, you know, I was working on, I wanted to have my brand of competency and credibility, right? I didn't want to be the lunatic who, you know, was talking about this crazy stuff. I didn't want to be that person. I wanted to be, you know, the chief medical officer at Express Scripts. I wanted to be who I was. And I was afraid of having this conversation and having my friends think I was crazy. I was afraid of that. But I decided I was going to try this, and I saw this data that said, well, the odds are in my favor. So I started talking to my colleagues and found out that most of them actually agree with all this. But they don't talk about it with each other, and that's why I'm telling you this. I don't know what you all think about what I've been saying, but if you think a national health program, if you think fixing Medicare and giving that to everybody is a good idea, I beg you, mention that to your physician, each of your physicians, next time you see them. Now, please, don't go in there with a stack of pamphlets and planning a 20-minute debate. Don't do that, because they're on retail. Time is money. They'll be relaxed and casual with you when they're with you because they want you to be relaxed and casual. But believe me, they know every minute of how they're spending their time, and they don't want a 10-minute discussion about politics unless they engage you, and they do, and that's lovely. But all I'm saying is, next time you see them, if you agree with this, just mention to them one sentence. By the way, Doc, wouldn't this all be a lot easier if we just, you know, fixed Medicare and gave that to everybody? And then move on. Don't dwell on that, you know, and don't bring it up every time you see them. Don't think you're going to repeat the messaging. Don't be an advertiser. Just mention it once, because I'm here to tell you, the more people that talk to them and say that to them, the more likely they are to feel comfortable bringing it up to other people. Not just your doctor. Talk about this with your kids, with your parents, with your grandkids, with your neighbors and friends, and with your reverend, and with everybody else. Engage the discussion a little bit. So anyway, that's why I'm showing you this data. You're not alone if you think this. Second task for Bob and Naomi. It's time for the handouts. I have a few more minutes of things I want to talk about that will address a little bit about what you brought up. But we have a handout that goes through a lot of the information. And I'd like them to help me and pass them out. So you have a little take-home. It's got our contact information and other stuff. So, and of course, if you haven't signed up on our email list, please do that. So, this I think is incredibly optimistic. This is the country that I believe in, the United States of America. We should be number one at everything. We have a country to be proud of. We have what it takes to do this in healthcare, right? We have all the pieces. We have arguably the world's best physicians, the world's best nurses, the world's best pharmacists, the world's best medical schools. People from all over the world come here for medical school. We have the best of this stuff. We have, as I showed you, plenty of the world's best technology. We need this stuff to have a good healthcare system. We have all the right infrastructure, right? We have Medicare, which isn't perfect, but we showed you how to fix it. So think about the Affordable Care Act. It's, as I said, there's a lot of things I like about it, but it's incredibly complicated. You try to go onto the exchange, and there's 30 different organizations, I believe the number is, that they have to check you against, including Homeland Security. If you create a username on the health insurance exchange, among the other organizations they have to network with is Homeland Security to validate that you're a citizen. So it's a really complicated program. Whereas on the other hand, we have Social Security that, you know, works pretty good for the most part. I mean, maybe it could pay more, maybe some things, but it works pretty good. You pay into it like you should with your taxes and such, and when you turn a certain age, they find you and they mail you a check or deposit a check for you. So that's the mechanism that every other modern country has used. It's something like Social Security, where they already know who we all are, and they give us a benefit. So today, they give us a check when we turn 65. Tomorrow, they could give us health care, too. The same simple, easy system. It would be simple. How long did it take to implement Medicare? Medicare was passed in 1965 as an amendment to the Social Security Administration Act, 1965. Now remember, the Affordable Care Act passed in 2010. We're at the end of 2013. We're struggling with its implementation. How long did it take Medicare to get implemented? Anybody remember or know? 6 months. 6 months. No computers. But it's a real simple program, and we could do a real simple program for this. There's no reason this has to be complicated, and we would retain our doctors and have a complete choice of our doctors for every American. And we do this. We need to do this. We have the best form of government. Our government embeds life, liberty, and the pursuit of happiness. That's part of who the American dream is, life, liberty, and the pursuit of happiness. We are the United States. So. Stay in touch for updates, help us spread the word, and all these things. And I think that's all that I've got. So, what else you got? Questions, comments? Did I drive you guys crazy? Could you hear everything? Have I made some of you mad? I have? So let's talk about that. Why are you mad? Who said that they're mad? Somebody said, yes, you have. Okay.
65-year-olds, you put up a slide that indicates who have a longer life expectancy.
Yeah.
20-year-olds do not, 25, 30-year-olds do not. Isn't there an indication that those young people, we went to our doctors every 6 months. When we had something wrong, we went to a doctor. Some of us took insurance when we were 35 to protect our health. My point is, probably 65-year-olds took care of themselves much better as young people than our young people do now. So my position is, it's education. It's not health care, it's education.
So I'm going to repeat this in case you all didn't hear, and then correct me if I didn't get it right. I showed a slide showing that life expectancy rankings against the world improve when you turn 65, and I was implying, actually I said, that that was because you get Medicare. And your point is that that's way too simplistic an approach, Dr. Weisbart. You're just glossing over many other variables, and I agree with that point. And that among those other variables are people that age group were educated a lot better, and we've let the educational system fall into neglect, and I agree with that. That people a generation ago, so to speak, were more focused on some of these important lifestyle issues. Obesity wasn't a problem then, for most folks who are over 65 today. They didn't live a life of being obese. We do now. So, I mean, there's consequences for these decisions, and I agree with you completely. But isn't it kind of a heck of a coincidence that it changes exactly at age 65? Exactly at age 65? It doesn't change at age 75. It doesn't change at age 55. It changes at age 65. That's a pretty heck of a coincidence. In addition, I didn't show you this slide because I thought we already have plenty of stuff here. But there's another analysis which I think is more telling. That maybe I should have showed you, because it does hit exactly what you're saying. This is an analysis that's been done internationally looking at deaths that were amenable to health care. So people who died because of not having health care. We're talking about strokes, we're talking about infections, we're talking about acute kinds of things, people who died from not having health care. And in 10 years ago, or 15 years ago, we were sort of in the middle of that pack of the rate. Over the next 10 years, that changed. We improved, but the rest of the world improved dramatically. And so now the United States stands out as having the most deaths per 100,000 under age 65 from causes that would have been amenable specifically to health care. Specifically to health care. That's a global study. I mean, there's a lot of countries that are in that. So that's another data point against it. But I don't at all disagree with the points you're making, that people are making some pretty terrible choices today, that they're not getting educated about how to best take care of themselves. I could not disagree with any of those points more. Of course, the economics are different today, too, where having access to health care as an employee is becoming less and less common. Having a health care benefit that has an affordable deductible and copay is becoming less and less common. 10 years ago, the average deductible was under $1,000. Today, 38% of working people have a deductible over $1,000. That's happened over the last 10 years. So the landscape is shifting, and it's becoming, the decision to go get health care that you need is becoming more and more difficult for people to make. But that being said, we do see people with their iPhones and with their, fancy TVs and stuff who say they can't. I see smokers all the time who say they can't afford their pills, and I wanted to slap the heck out of them because you know how much you're spending on this, So there is certainly a component of that to it. But the data would tell you that most of the reason that everybody around the world has those kinds of behavioral problems, and the data would tell you that the key reason that America is different in life expectancy from the rest of the world is because of the way we've chosen to organize healthcare. We waste money. We could say by fixing the organizational structure of it, our costs would plummet by more than enough to afford to provide care to everybody. So I kind of agree with you, but I kind of don't. Was that what you were asking about? Oh, yeah, education. We're not doing so good at that. Yes, please.
Yes, that's a tax bill. What
So I'm going to try not to talk about this for an hour because, believe me, having worked for 8 years at Express Scripts, what you just raised is an issue that's like I spent years working on the issue you're raising. She's raising the issue of why would a moral and ethical physician even consider prescribing that drug that's $135 when there's a $4 alternative? What the heck is going on? And I would say that's I could not agree with you more. And doctors are getting better about this, but doctors are busy. If you ask them, they don't care so much about this. If you ask doctors, do you talk to your patient about the cost of drugs? They actually say no. If you ask patients, do you talk to your doctor about the cost of drugs? Even if they're paying out of pocket for everything, they say no. Less than half of patients who pay completely out of pocket for their drugs talk to their doctor about the cost of drugs or their pharmacist. So they're not having the conversation. Instead, they're seeing the advertisements on television saying, the television ads aren't going to tell you that Brisdell is the same as Paxil. The television ads that I haven't seen yet are going to show you hot flashes. Oh my God, this is horrible. And I gave this talk yesterday, actually, and I said, you know, so how much would you pay for a drug for hot flashes? And there was a guy in the audience whose wife must have been going through menopause, and he said, I'd pay $1 million. So they show you the drug, and they show you the problem. They don't mention what I just said to you, and then you go to see your doctor, and you don't know this. You don't know that it's the same drug. Why would you know that? So you go to see your doctor, and you say, doctor, I saw this ad for Brisdell. I'm just picking on Brisdell. There's thousands of these examples, but sorry, Brisdell, whoever you are. But you go to your doctor and you say, doctor, I really would like a bottle of Brisdell. These hot flashes are driving me up a wall, and my husband said I should come in and demand this from you. Can you give me a prescription for Brisdell? And so, remember, I'm busy. I'm retail. Time is money to me. I'm being nice to you, but I'm in a friggin' hurry. And so I could say, yes, here's a prescription. Or, now you came in asking for the drug, not knowing, just asking for the drug. It would take me, having done this discussion, probably 15 minutes to persuade you that generic paroxetine is just as good as brand Brisdell. That's not an easy discussion to have with most people. That's at least 10, if not 15 minutes, for which nobody's going to pay me. And so I'm probably going to say, okay, you want that? You know it's expensive. You know, yeah, I know. You know, I might say, you know, there's a cheaper generic drug. You know, those generics. I'm allergic to them generics. I mean, people say that kind of stuff. To me, I've heard this. So I have a choice. You come in demanding it because you, frankly, are not, you don't know as much about it. You come in, you saw the ad, you think it's a problem, and you want to come in, you want the drug, you come in, you ask me, and I have a choice. I can write the prescription and move on to my next patient and collect my $100, or I can spend 15 minutes having an argument with you. You'll leave unhappy. You'll leave with this really funny look on your face of, I think it's the same thing. And I'll leave, and you won't, and my doctor, he wouldn't, you know, I don't know. So I'll have a less happy patient, less likely to come back to me. I'll make the same $100, and I won't see 2 other patients. The interests aren't aligned here. It's an economic issue, right? It's an economic issue. So, and that's why we then have this infrastructure of benefit designs where they make sure that you have to pay the $135, and they make sure that somehow you find out about the $4. So there's systems for that. But and just to make it worse, the FDA has approved Brisdell for hot flashes. The FDA has not approved paroxetine for hot flashes. So the detail rep is coming in to see me. You know, you go to see the doctor and you have to wait half an hour because there's 3 other people who come in carrying little cases and feeding lunch and all this stuff. You have to wait for them, the detail reps. You're getting me started, I'm sorry. So they've been telling me to prescribe it. If I don't prescribe it, they know that I didn't prescribe it, and they can do things to me, literally. I mean, they can cut me off from supplies for my cabinet. They can cut off lunches to my nurses. They have consequences. So they've been doing that. And then I've got to prescribe this drug that's technically off-label. If I give you paroxetine, generic paroxetine, and not Brisdell, that's not what the FDA has given that as an indication for. How important is that? How important is it for me to prescribe only what the FDA has approved? It's not even remotely important. It's not even remotely important. It's completely about which drug company spent the money doing the research to market in that particular way. It's not even remotely important. But some of them